review because I like the way that they simplify a lot of the things, and we can just sort of talk about that and have a few discussion points, and then just jump in whenever you're ready, guys. So this article was a randomized trial of general strength and conditioning versus motor control and manual therapy for chronic low back pain on physical and self-report outcomes. So we're talking about a general strength and conditioning group versus a lot of the sort of motor control and manual therapy. So there's a bit of a few things going on here. All right, so a bit of a background. Worldwide, low back pain, the leading cause of disability and reduced function that has a great cost to the world. And chronic low back pain is a problem identified that's persistent over 12 weeks and is believed to account for the majority of these costs. Treatment of chronic low back pain can consist of conservative measures like these exercise interventions or manual therapy. They've been shown to be just as effective as surgery, but at a much lower risk and much more cost effective. As the condition is heterogeneous, meaning it affects a wide variety of people, treatments should be individualised and measured objectively, not solely focused on pain intensity. Strength and conditioning, manual therapy and movement control have all been studied in relation to pain intensity, but it is less known about their efficacy with other clinical outcomes for chronic low back pain. So I'll open it up to the floor, and I guess for the 6 months here that I've been in Ives' clinic, I haven't seen too much proper chronic low back pain. I've seen a little bit of acute low back pain, but not so much proper chronic low back pain patients. So I don't know about your Ives. What's your sort of experience in the area?
Yeah, no, seen plenty of chronic low back pain in my time. I guess I'm interested to see before I even get into the article, everyone's thoughts about strength and conditioning versus motor control. I guess when I started practicing a long time ago, we used to really spend a lot of time with ultrasound machines and work on TA and multifidus and spend ages trying to get that right. Whereas now I feel like I'm a bit more functional and practical, but I don't know if I'm throwing the baby out with the bathwater. I'm actually intrigued to hear what Laura has to say about it, because I'm sure you'd see a few more clients in this area, and your thoughts about just this concept about motor control versus strength conditioning and where you feel that they fit into a continuum. So do you want to hit us up with how have you treated, and how's that changed, and where you're at the moment is probably my question.
So my disclaimer is that when I was at uni, I struggled a lot with this whole concept, and they'd be like, okay, so you start with this and then you move to this and then you move to that, like essentially with TA training and stuff like that. And I was not particularly good at it, so I didn't do a huge amount of it. So I did do like, some TA and some like core strengthening, as you would call it, but have definitely moved, I think, as well with my own experience in terms of like my own strength training and stuff. So moving away from that real specific stuff to more like functional and goal-oriented stuff, because I think a lot of people don't get it, and also it's not that functional in terms of like when you're doing that specific training. So I wonder if people's compliance is less because they don't see the point of it. So I still will teach activation and that kind of thing, but I'm more concerned with like movement, and particularly for chronic low back pain patients who, like, if you watch them flex, for example, you'll just see like a heap of muscle guarding or very limited like movement through the spine. So I'm much more about, I think, mobility in these kinds of patients rather than strength and encouraging them to switch everything on.
Yeah, that's a really interesting point. And it sounds like your methodology to treat them has changed over the many years you've been a practicing physio.
Yeah. Do you have to put that many in there? In a few years?
You have the most you have the most clinical experience out of all of us. So I wanted to relay it. I'll stop having a go at you. I just like having fun. But I think that's a really good.
Yeah, that's something I learned, I think, more so when I went back and did my master's, was about like that movement quality and what are you actually looking for when you do like a range of motion assessment.
Yeah, no, so, I think that's fantastic and some great insight into where you've come in thinking. And that was a master's in, just to be clear, that was a Musk master's, was it, Laura?
Yeah.
Yeah. Cool. Cool. Wazim, do you have anything to add just from your clinical experience, what you've seen with motor control versus strength and conditioning, and how you've embedded into practice?
Yeah, so going through uni 2 years ago, we probably learned a little bit more than you guys about, away from just manual therapy or motor control, and a little bit more like the goal-oriented stuff and things like that. But I still feel like at uni we're still taught like that process of assessment of TA and all that sort of stuff. I feel like we don't get too much of assessing person, things like kinesiophobia and all that sort of stuff while at uni, which we know now it's a huge thing at the moment. So like what Laura said, like looking at their movement and all that's super important, but I also think that learning how to assess the person and what could be driving or their pain is a bit hard to get your head around when you're a new grad, because someone comes in and they've had pain for 10 years and they've got like all these beliefs that they come on with. Like, I've seen a chiro, it feels great when I get my back cracked, or I feel great with the massage. And trying to change that belief or trying to work with that belief is hard. I think that's a big skill at the moment, is learning how to navigate that side of it. On top of all the motor control and the strength and conditioning that is super important as well. But yeah, I feel like we got taught more of the motor control continuum as opposed to like pretty much nothing we learn at uni was strength conditioning at all. So yeah, I think that's a huge field at the moment. They talk about the hybrid physio, obviously with exercise physiologists as well. They're super important. So I think it's a big gap in the knowledge that we've got.
I really, really like what you said there, because you brought a few things into account which I really wanted to think about before we actually talked about the article, which was holistically looking at all the reasons why people might experience low back pain. I think is really important. I just did a whole heap of ergonomic assessments this morning by telephone, which was interesting for people in Melbourne. That was an interesting but fun thing to do. But a lot of no one was even considering their ergonomics as to why they're contributing to back pain and things like that. So that's just one consideration that just comes to mind. But the strength and conditioning element, I think, is so not well taught at university, and it's not good enough to just pass the buck to it. There's got to be more hybridity. I think there's still a real good place for pure strength and conditioning coaches and physios to work together. And I think about ACL rehab end stage. I think there's a skill set there where we should be passing on to them, and they can really take people to another level. But like you said, Wazim, why are we not embedding it a bit more into our own practice to help people have good outcomes? My bias will probably be a bit like Laura's, where I feel like I learned so much about activation stuff, whereas now I'm so much more functional mobility wise. So I'm interested to see what the evidence actually is saying about that. So yeah, let's dive in. Jack, do you have anything to add before we move through the article?
No, I just loved all those comments there, and I think I'm very similar, but I didn't really we got taught the multivital stuff and the TA activation and all that at uni, and it didn't grab me with all that much enthusiasm. I didn't like it either. But I think just the notion of trying to individualize everything, trying to teach someone to do a TA activation and all that stuff, it's not the most isn't the most functional stuff, and they might not get that either, and that might come into adherence level as well. So just I'm in the same boat. We don't get taught enough about the strength and conditioning at uni, and I think it's so important. But let's go into it. So the methodology of this one, taking two common but distinctively different interventions. 40 participants were randomized equally into a general strength and conditioning group and a motor control and manual therapy group. So the general strength and conditioning underwent a 6-month program consisting of weighted push, pull, trunk extension and flexion exercises plus cardiovascular conditioning. And they had two 1-hour sessions for the first 3 months and then one 1-hour session per week for the second 3 months. The MCMT group had 12 half-an-hour sessions across the 6 months. So that their sessions were a little bit more spread out and they received a lot less sessions. And these sessions included exercise prescription aimed at the transverse abdominis, multifidus and pelvic floor. And the progressions were pain contingent. Manual therapy was also performed at the discretion of the physio. Both groups had home exercise programs and the MCMT had additional cognitive behavioural advice on movement control, and the general strength and conditioning group were given mental rehearsal exercises to address kinesiophobia. Outcome measures were taken at baseline, 3 and 6 months, and these were paraspinal muscle size, trunk extension and flexion endurance tests, 1 rep max leg press, endurance leg press, and cardiovascular endurance ramp protocol, plus a series of self-reported outcome questionnaires. Yeah, so a bit going on there, and like two very different sort of groups, two different sort of methodologies and two different, I guess, you know, one had a lot more sessions, one had a lot less sessions, a lot more spread out, and there's a bit going on there. Any sort of question, anything that stood out in the methodology there?
I reckon like the fact that the manual therapy was like at the discretion of the physio, so there wasn't really any consistency across what they received. But then it's probably a bit more realistic because every patient is going to get something different. But that kind of stood out to me as like you don't really know.
Yeah.
Yeah. And was the advice they were given the same? How many different physios? Like all of that kind of stuff.
Yeah. Yeah. There's a lot of variables that sort of weren't.
Yeah.
The thing jumped out at me is just how variable that methodology was when I read it the first time. I'm like, well, I'm interested to discuss the results, which we'll get to shortly. But I was like, well, how relevant and applicable are the results when there's so much variability in what you do? Yeah. And like Laura said, it's not just the manual therapy, but we know how important communication and how that plays a part. Patient, you know, you did the iMove course too, didn't you, mate?
Yeah.
Yeah, you did it online. So you understand those principles about patient physio relationships, that all plays a very important part in the outcome.
Sure.
And I think if that's such a big variable, I actually question how would the results vary as a result of that. But we'll dive in and see.
Just on that as well.
Yeah.
They don't say if it was just the one physio that treated them or a different one, and that they gave cognitive behavioural advice as well. So obviously between physios that would be different as well. So like what you said, patient therapist alliance. We don't know. Maybe one of them had a good therapist alliance, and then another one didn't have. Obviously that changes results. So yeah, quite variable.
And I think it's important to consider that because I think you guys might agree with us here, but we put so much emphasis on that in our clinic here, and to just to have that as a variable, I think it makes me question exactly how accurate some of the results would be, unless that was a bit clearer. But it'll be good to see what happens for sure.
Mm-hmm.
So the manual therapy group attended 77% of their sessions, and the strength and conditioning group attended 60% of their sessions. The trunk extension and flexion endurance increased more in the strength and conditioning group at both 3 and 6 months. 1 rep max leg press increase in the general strength and conditioning group at 6 months, with leg press endurance increasing at both 3 and 6. Cardiorespiratory fitness was greater in the GSC group at 3 months only. Reductions in pain intensity favoured the manual therapy group at 14 and 16 weeks. And then the Westbury Disability Index and Tampa Scale of Kinesiophobia both favoured the general stretching and conditioning group at 3 and 6 months. And multifidus muscle volume increased at 3 months in the GSC group.
Are there any results that jump out at anyone that you'd like to discuss?
Like multifidus muscle volume, so that would probably argue that specifically training that muscle is not super effective. We were just talking before about, like, I couldn't even tell you how to actually specifically activate that.
I can't even remember.
It's something about, all I remember is, like, you want to feel that muscle, like, swell under your fingers, but, like, what the hell? Like, I don't know. I couldn't even tell you how to do it. So,
Riley, do you remember where the multifidus is? It's just in the back. So just as the physio here. Yeah.
Is that the one where you do like the glute bridge and you like got to curl your back downwards?
I can't even remember.
I feel like we were taught in 4-point kneeling, but like, also some kind of curl, and you want, I don't know, tuned out because it didn't make sense. Is where I'm at.
Very hard to specific it.
Like, people that like have good body awareness, like I would assume most physios have good body awareness. So then you go and train that in somebody that doesn't have, that same awareness. It's hard.
Someone with chronic low back pain, they'd be struggling to get that.
Yeah.
And how functional is it to helping their symptoms?
Yeah, exactly.
Please.
Yeah.
Was there anything else that jumped out at you, mate?
I feel like obviously with the strength conditioning, some of the outcome measures as well, and even like how many sessions involved as well. So like people attended 9 out of 12, although that's 77% compliance. There was 52 sessions in the strength conditioning. So I mean, those to say that 77% versus 60% people are more compliant with manual therapy, I don't know if that lies too much, because it's just a massive difference. Like
apples and oranges.
It's hard to draw that conclusion from that as well. And then the 1 rep max leg press as well. Like, you're not going to get improvement in that from doing like multifidus activation. So even like leg press endurance and all that sort of stuff. That I'd probably disregard that whole dot point, to be honest.
Yeah.
I think there's a lot of dot points you have to disregard with him, to be honest. It's not very applicable, is it?
No.
That was one that jumped out at me. I'm like, how can you compare 9 out of 12 to 31 out of 52 and then just say manual therapy has more compliance? Which it probably might, but I don't know.
But also, like the results, like in the strength and conditioning, they had 3 times the number. Like even with shitty compliance, they still had 3 times the amount of intervention. So if you look at how many attended the manual therapy group.
What about you, Jack? What were you going to say?
Yeah, I was sort of in the same boat was him, like, having the testing of the trunk extension and flexion, and then 1 rep max leg press. Like, there's no need to test all that. The general strength and conditioning group is going to be ahead.
Yeah.
We could just talk about the attendance, the pain intensity, and then the outcome measures. I think we could just cut it at that, and there'd be the 3 talking points that we want to talk about. But even then, because there's been 52 sessions compared to 12 sessions, it's tough to compare them.
Well, then what I'll ask is, you go first. Sorry,
the reductions in pain intensity, I know it does come to it. It's not actually that. I don't think it was clinically
significant
thing. But to have a little bit more reduction in pain with the manual therapy group kind of surprised me at 4 months in. But
are there any other objective measures you think would have been more useful to track to see how effective this is?
I wonder if like a patient specific, what is it called? The patient specific functional scale or something, where it's actually meaningful for like the client.
Yeah, I was thinking of Roland Morris, which was the back specific one. That might have been good to see. because it's pretty. I didn't read the long article, but I wonder how they tested cardiorespiratory fitness. I'm intrigued as well. I don't think they would have done a VO2 max test, so I'm intrigued to see what they did there.
Did they do? I can't remember.
But yeah, I think that would be a good. Is there anything else, do you think, if you're treating a back patient and you want to use these interventions, you'd be like, oh, it'd be nice to see this change over a 3-month period?
Not that it would change, but what I would add in, like they talk a lot about activating muscles. What about those people that need like deactivation? Like what about those people that are really just like switched on, which I probably find with most of my chronic back pain patients, it's possibly presents as weakness, but it's probably just that everything is so switched on. So it doesn't account for any of that, which I spend a lot more time trying to get people to relax things than I do activating things, particularly when something's so chronic.
That is such a good point. Yeah, absolutely.
I don't know how you measure that, but they just haven't like thought about that at all.
Yeah, I think that's a really important consideration, and that's a really good outcome when those muscles don't turn on as much. As a consequence, pain generally comes down as well. So that's interesting. Was there anything else you can think of that they might have missed that before we move on to the limitations, mate?
They said they did a bit of mental rehearsal and cognitive behavioural advice. I've got like the Tampa scale, which is mesiophobia. I don't know, maybe they could have added some more regarding like behaviour, some top outcome. I don't know any off the top of my head, but I know there's a few for belief. That they could probably put on there, but other than that, I think you guys.
Yeah, no, that's good, and I think it's just important to consider everything. I think as we go through this, it's really important because in its essence, just SNC or just activation is not enough. So I like that we're still talking about those things, even though it wasn't specifically related to the article, which is good. All right, punch through, Jack. Tell us, let's look at these limitations.
So a few more limitations. This paper was secondary to a primary clinical trial. As such, you have to do a bit of jumping around to find the methodology details. The primary outcome was looking at intervertebral disc health, which meant that there was no subgrouping for this paper, suggesting that treatment interventions may not have been matched for the individual. Another thing to note was the value of personable interaction with a therapist in chronic low back pain, with increased likelihood of validation and reassurance in the manual therapy group. Perhaps this was one reason why the manual therapy group had improvements in pain reporting and a better adherence rate in attending sessions. The two groups in the study were also difficult to compare. As mentioned, the MCMT group had less sessions than the SNC group, but these sessions included one-to-one therapy. It is not clear if the SNC group was one-on-one or class-based, and progressions of the two interventions were also different, with the MCMT group progressed based on pain and the SNC group was progressed by time. So I think that's a good one. The one, it wasn't clear if it was one-on-one sessions or group classes.
Well, that jumped out at me because that's completely different.
Yeah. I mean, 52 one-on-one sessions.
Yeah. Well,
both interventions address the psychology of chronic low back pain, but again, these were different, with cognitive behavioural education with MCMT group versus mental rehearsal to address kinesiophobia in the S&C group. These multiple variations in methodology make it difficult to drill down into why the two groups responded differently. So I think that agrees with what we discussed.
Did I also completely miss the part about who actually provided the strength and conditioning?
Yeah, I don't think you mentioned it.
Oh, I think it was exercise physiologists.
Right.
Okay.
And like some students as well. I'm not sure.
And some oh man, it just makes such a difference to know who was doing it and their skill set.
Yeah.
You know, Imagine, Riley, if we just said, "Oh, can you run an S&C class tomorrow with the little bit of knowledge you've learned from uni versus us?" Yeah, I think there might be a different outcome to our clinical study if Riley ran it versus to Jack I ran it just quietly. Sorry, Riley, not quite there just yet. So we'll get there.
3 more years.
Even like a physio versus like a personal trainer or an exercise physiologist, or it's
definitely question.
Actually, it says where but not who. Did you see this though? Supervised, but it doesn't say who.
That one was certainly something that jumped out at me.
Even one-on-one physio, like manual therapy by physio or student-led exercise class. Yeah, actually talks about the exercises and everything, and that it was supervised and where, but actually not who did it. I don't think.
I read it somewhere. I remember reading it somewhere. I don't know where.
We'll figure it. But yeah, like even that, the fact that you have to like skim through.
Yeah. Well, there you go. That was a big one that jumped out at me. That's a massive limitation. Was there anything else, very quickly, that anything else you'd like to discuss? Open floor. That's a good. That was a big one for us. Let's look at the clinical implications then. Cool.
Yeah. So the ongoing debate around manual therapy plus or minus strength training, or one versus the other, is unfortunately not going to be settled by the results of this paper. Go over. Physical outcomes, fear of movement, and perceived levels of disability in patients with chronic low back pain appear to improve following S&C and mental rehearsal of movement. Yet there is better adherence with interventions that include manual therapy. Knowing that one has better results objectively, but the other has better buy-in from patients, can you surgically remove one from the other? Should we be more open that we perhaps don't know what manual therapy does, but acknowledge that contact, validation, and personal touch may be beneficial nonetheless? It was suggested that pain intensity should not be a focus of chronic low back pain rehab programs, and the results in this study support that. Changes observed at 14 and 16 weeks in the MCMT did not meet clinical meaningful thresholds, and there was no difference between groups at 6 months. Therefore, measures of physical outputs and perceived level of function should be favoured over pain scores. An increase in paraspinal muscle volume is likely due to the load prescribed in the S&C group, where movement control alone would not be enough to elicit hypertrophy. The S&C group exposed to higher loads with lower limb weights and trunk-specific exercises would have undergone isometric contractions around the lumbar spine at a higher percentage maximal voluntary contraction than the MCMT group. A study in 2019 demonstrated that there was no relationship between cross-sectional area and level of disability with chronic low back pain. Localized hypertrophy may therefore be an associated outcome, but not a key contributor in this condition.
Jack, you want to jump in first? What was your big little take?
Yeah, some good points there, I think. I think it was, the big one, just sort of not focusing on pain with chronic low back pain as a outcome measure. And the fact that, with the manual therapy group at 16 weeks, it wasn't at a clinical meaningful amount, and then there was no difference at 6 months. So, again, not to throw the baby out with the bag, but with the bathwater, as I'll steal one of Ives' sayings.
Yes, I'm an old man. Get it.
But not focusing on pain should be a key thing with chronic low back pain.
Yeah, no, that is one useful thing came out of it. I'll jump to you, Wizim. What did you take from that, mate? Anything jump out?
Yeah, so with obviously the manual therapy and all of the stuff that's around at the moment, we still do know it does something. Obviously, we don't know exactly how long the effects last for. But my stance on this is, why can't we do both of it? Why can't we do the manual therapy? Why, if we assess something and someone doesn't have good motor control, obviously that can be done, and also the strength and conditioning with it as well. So I don't know if there's, I actually don't know if there's been any studies done that combine them all, like manual therapy, strength and conditioning, or if there's been any conclusive evidence around that, and if that's any more effective than manual therapy alone or just strength. But yeah, I feel like, you know, although manual therapy, as I said, we don't know exactly how the effects come about or why they do, whether it's contact validation or, as you said, touch. But, you know, we do know it does something. So I feel like as physios, that differentiates us from other professions. So why not? And the other thing as well is we need to collaborate more across physiology and S&C as well. So obviously we probably can't do the 1 hour contact time with a patient doing exercise. So, you know, I think that's probably better done with exercise physiology or S&C. And then, you know, from a physio standpoint, we can obviously, we're probably a little bit better at assessing injury as well. So I think that, yeah, it's probably has to all happen. Just, yeah, I guess combining professionals or working together with.
Yeah, no, that's awesome, Wizim. Thanks. Laura, do you have anything to add?
So I'm back on the point of like measures of physical outputs and perceived level of function should be favoured over pain scores, which is all well and good, but what about those people that are just obsessed with their pain? So like I'm aware that like we can read this study and be like, okay, function is a better measure, but how many times have you had that conversation with a chronic pain patient and they come in and you're like, okay, how did you go this week? And they'll be like, oh, my pain's the same or my pain's worse. And you just spend all this time saying, okay, but you did this much activity this week compared to last week. So even though your pain's the same, you're probably actually better. So I feel like it's all well and good to say that, but what outcome measure is the most important for the patient in terms of that? And I know that that comes down to our education and changing those beliefs, but I think for someone that has chronic pain, that's a big driver for them in their recovery and a big measure of how their recovery is going. So I think that's something that kind of has to be considered a little bit. And again, yeah, I would say, like I agree with Wazim, like why not just do everything? Because that manual therapy also gives you that opportunity to educate the patient. And whilst it might just be a short-term change, it then gives them that window of time to work on all of those other things, whether it's down regulation, whether it's like them being more receptive to the education you're providing, building that trust, giving them an opportunity to talk as well. So I think, yeah, I would do all of it, but look at where our limitation is and who we need to add into the picture.
Okay. Also on that, if someone comes in with chronic low back pain and they've already got these beliefs, and they come in and they're expecting you to put your hands on them or whatever it is, and then if you take a stand straight away and then just not do any manual therapy or not do any touch and just come straight into an hour of S&C, you know, it's possible that you probably might lose them. Whereas if you could probably use manual therapy as a tool to slowly wean them into more of an exercise or try and change their beliefs over time, as opposed to just first session straight off the bat say, look, manual therapy doesn't work for chronic low back pain, let's not do it at all, and then just jump straight into an hour of S. I feel like that's probably not going to change their beliefs too much, and we know that with chronic low back pain patients is huge. So I reckon it's probably can be a tool like what Laura said. If someone's obsessed with their pain, are you going to just focus on function, or we try and bring their pain down while working on function, while improving what we need to improve? So it's a bit tough, you know, because everyone's different. Someone might come in and they'll be happy to do an hour of SC, but someone comes in and, you know, they're expecting something and then you just straight off the bat hit them with pain science, you know, are you going to lose them, or do they want that, or do they not? Yeah, I guess it's something that's.
I couldn't agree more. I wish more young people thought like yourself. I'm lucky enough to have come off 2 years at teaching at university and met some good people. But there's a lot of people have this mindset that if it's not evidence-based, you shouldn't be doing it. When I'm like, oh, wait a minute, I understand what you're saying, but you have to look at how you interpret that evidence and what you work with it and how you use manual therapy, because that's really important, because expectation is so important. And I would love all those people to have only seen chronic back pain patients who are on EPC schemes and see how they deal with telling them that they're not allowed to touch them or ultrasound them or differential them and only do exercise. I reckon that would be a lot of fun times for a lot of young people. But I digress. I think it's so important. And I think the article even shows it's that holistic avenue. It's not like, you know, there was no evidence to say only strength and conditioning. There's ways and means to embed all things to help get a good outcome. And we have to consider that, which is really good. So we'll finish with this. Your top takeaway and what you'll implement from reading that. It was actually interesting from my point of view, because I think there's a lot of limitation in this paper, to be honest. So I think we need to take a lot of what we've gone with a pinch of salt. I'll let Riley, who's been quiet there, talk first. Is there something new you learnt that you're going to take away from you? Hopefully all the anatomy talk didn't go over your head.
Yeah, I don't know. There was lots of words. I was like, what are they called? Like phrases and stuff. I was like, I've never heard that in my life. But anyway, I don't know. I feel like this, like, I didn't take much of what was said in the paper, because I just feel like it all just contradicted itself. So I was just, I don't know if I should
confused.
Yeah, I don't know. But it was just more, I think I got more out of listening to you guys talk and seeing what you guys think and what you guys got out of this. And yeah, just interesting to see how one thing can say something and then you can think another, and just everyone's, how everyone would go about taking on this client or something. So yeah. Beautiful.
All right. Thanks, Riley. I hope that'll help you as you're continuing to learn.
Welcome to the grey.
Yeah, welcome to the grey area that we live in. Cool. Jack, what was your take home, mate?
Yeah, it wasn't like a massive take home, but it's just sort of re-emphasising how important it is to individualise each treatment to each individual. Like, as Wazim said, like you can have someone who is coming to physio for the first time and they hear, physio is, a lot of hands-on sort of stuff. And if you throw them straight into the gym, they're going to freak out and probably not come back. But again, on the other end of the scale, you get someone in who's had back pain forever and they've been really active, and their expectations is they want some expert advice on movement. So you really just got to tailor what you do to the individual and try and work out that individual as quick as you can.
Nice. Yeah, thanks, mate. Wazim, what was yours?
I think one of the big things from this is that, I kept saying the word, but like the hybrid type of physio, I feel like we're moved far away from just the manual therapist physio, and obviously multidisciplinary, like involving exercise physio. I feel like that's right now, not just for chronic low back pain, but just in general, it's at the moment. And like what you said, like a holistic approach is probably better than just one way. So yeah, I think the takeaway is that there's no one cookie cutter approach. I think it's using the whole range of things. Not just the one is probably the most effective from what we can see, but yeah, super grey area. So yeah, I don't know. I feel like a lot of these studies are inconclusive, but yeah.
No, Wazim, it's like you said, living in the grey is what we do. But I think if you individualise it to the person in front of you, I was just talking to a colleague yesterday about sort of just some thoughts about the profession. I was just saying that too often we treat the condition, we don't treat the person. And I think that's what you're alluding to. Treat the person in front of you, look at all the elements that are contributing to how they're feeling, and come up with an individualised program to help them. And how you treat a 75-year-old nana is definitely going to be different how you treat a 30-year-old athlete. So I think that's pretty cool too. And Laura, you want to round it up? What was your take?
I think just in general, not specific to this article, but a lot of physio, and we've spoken a lot about this here, is managing expectation. So once you are not meeting the expectations of a patient, then you're not going to have that buy-in. And we learnt when I did the evidence-based subject, back when I did my master's, I think a really important thing that they spoke about was evidence-based practice being like 3 main areas. So like the research evidence, the clinician experience, and the patient expectation. So once you put all of that together, then you can have a plan. And I'll often, if I'm doing something that I know doesn't have a huge amount of evidence, but I'm like maybe at the end of where I want to be, I'll even explain that to a patient. I'll be like, look, the evidence doesn't support this, but let's give it a go. It's either going to work or it's not. So I think it's about communication, education, and looking at the whole picture and the whole person. And every research paper you read in physio says it's inconclusive. So it's like, where do you go with that?
I think that's a perfect way to finish, actually, of some pretty fun discussions. You've got to look at everything in its due context. I really like that we picked this paper apart and actually discussed those limitations, so we can actually now apply the findings of it. And the findings are not too dissimilar to how we lent into this conversation, which is looking at the bigger picture, looking at all elements and not being stuck upon just activation, just strength and conditioning, just manual therapy. It's actually the whole picture. But yeah, not a bad way to finish off. Thank you for the discussion, guys. I hope you enjoyed it.